Yeah, my name's Alf Collins. I'm National Clinical Director for Personalised Care in the English NHS. Part of my policy portfolio is shared decision making. I also have personalised care and support planning, social prescribing, linking people to community assets, support for self-management and health literacy. And I'm going to just share with you some thoughts and ideas from my particular policy position in England. Our approach to healthcare is primarily disease or condition centric, not primarily person and community centric. And those two facts lead to really predictable consequences, including this. This is the problem of multimorbidity, the problem of a highly medicalized approach to supporting people to keep as well as possible across their lifespan. I've been part of what's called a national overprescribing review in this country, and I was horrified to hear that the highest number of different medication the person was on in this country was 57. So there was a patient in this country on 57 different sorts of medications, not 57 pills a day, 57 different sorts of medications. And I'm sure there are still many patients in the 40s and 50s. It's a problem. It doesn't necessarily add to people's quality of life. In fact, the evidence is pretty clear. If we over-medicalise the support and care that we provide for our population, we add to the so-called burden of treatment. So the burden of living with health conditions is added to by a health system that doesn't account for a person's assets, a person's ability to engage with their communities to keep well. And if it highly medicalises care, this is what happens. We add to the burden of living with long-term conditions rather than taking away. There's some really stark figures from this country. 3 years ago, there was a review just prior to the pandemic of the numbers of people taking 5 classes of dependence-forming medicines: opioids, GABA drugs, benzodiazepines, and antidepressants. And what that showed is that about 25% of our population, adult population, is taking one or more dependence-forming medicines in the long term. And the mapping between those numbers of people, those percentages of people, and deprivation is absolute. That map on the right is the numbers of people on opioids in this country, and it almost precisely maps onto areas of deprivation. There are about 30 to 33% of our adult population are on one or more dependence-forming medicine. So there's the background. We're over-medicalising. We're focusing healthcare in hospitals and focusing on medicines and operations. And, our health services themselves are starting to become sick because of that. One of the ways in which we assess the quality of our health services is to look at waiting times for elective care procedures. The waiting times on the left are in days. And these are 4 different procedures: cataract surgery, hip replacements, knee replacements, and coronary artery bypass. Huge variations across Europe. Australia and Canada and New Zealand are also in this OECD health statistics survey. But huge variations, but almost universally, people prior to the pandemic were waiting a very long time indeed. And of course, along came the pandemic, and these waiting times in my country, in England, they were going up from 10, 12 years ago. The numbers of people on waiting lists, they went down during the pandemic, and they're rising very, very fast indeed. There's nearly 6 million people waiting for elective surgery in this country. But it's just one marker of the quality of a health service. And across the developed world, we now know that our health services are under enormous strain. And the one thing that the pandemic has done for us is it's really, really shone a light on deprivation and inequalities. Pretty much any condition you can think about, including COVID, is more likely to happen to people in the most deprived areas. People in the most deprived areas are more likely to collect, if I could use that word, long-term conditions and health conditions. And of course, they're much more likely to die younger than those people in the less deprived areas. So we have worldwide a massive inequalities issue. So quite frankly, our health services we've talked about it for years. I've been in the health service for 45 years, but our health systems as currently configured are unsustainable. There's some fantastic work from colleagues at Oxford University talking about the rigorous pursuit of biomedical goals and strict adherence to single disease guidelines is part of the root of the problem. And what we really have is an overdependence on healthcare as provided by hospital-based specialists and services. We have to turn the tide of this, or there will be no health systems, certainly for our grandchildren and possibly for our children. There are currently multiple ways of thinking about this. I've just been following on Twitter the Preventing Overdiagnosis and Overtreatment conference in Calgary. Some amazing work going on there, but it's quite segmented. It's separate to the Global Social Prescribing Network, for instance, or all of the work that's going on internationally around high-value healthcare, which incorporates a focus on patient-reported outcomes as compared to clinical outcomes. And of course, for those of you that know it, Choosing Wisely and its international kind of offshoots, including slow medicine, has really focused on how can we prevent overdiagnosis and overtreatment by focusing on what matters to individual patients and helping them and supporting them to manage their own health and well-being, to make decisions about their health and to connect with their assets in their community. Our time is now. Our time really is now. And unless we actually move forward swiftly together to empower people to manage their health and well-being, to make informed decisions about their healthcare and to keep well, drawing on, investing in the assets in their communities, there will be no health systems worth thinking about in 40, 50 years' time. Our time really, really is now. It's the Goldilocks principle. We need to provide just the right amount of healthcare for individuals and populations. The evidence is we're providing too much on the one hand and too little, or the wrong stuff in our deprived communities. We need to get it right. We need to support people to thrive. We need to start thinking of the What Matters to You movement, not just as a nice to do, but absolutely at the core of the way that we think about providing healthcare. It's about partnership approach, supporting people to focus on what matters to them, focusing on their goals, focusing on their values, their preferences and their strengths, and supporting them to move forward in their lives. Empowering people and communities is not just a nice to do. The only thing we can do to ensure our health systems are sustainable.